Very warm welcome to my talk on acute pancreatitis. Acute pancreatitis, as the name suggests, is acute inflammation of the pancreas. This can be mild or severe. In its severe form, it has a very high mortality. Today, I shall go through these some of the important aspects of acute pancreatitis, the causes, the pathogenesis, the clinical features in particular, and the diagnosis and treatment of this important disease of the pancreas. Okay, this slide shows you the anatomy, the location and structure of the pancreas. As I said, the pancreas is a retroperitoneal organ situated in the upper abdomen. Okay, it is shaped like a leaf with its base fitting rightly into the C shape of the duodenum. It consists of a head, body and a tail. Okay, this is closely related to the duodenum, the stomach anteriorly, the splenic artery and the vein posteriorly. These are all important structures, and the portal vein is also behind the head of the pancreas. Histologically, there are two types of cells. One is the acinar cells, which secrete the digestive enzymes of amylase, trypsin and lipase. And scattered among these acinar cells, which form the bulk of the organ, 80% or so, are the islet cells, which are endocrine cells, which consist of the alpha and beta cells, which secrete glucagon and insulin respectively. Okay, now we come to pancreatitis, which actually is inflammation of the pancreas. There are two types of inflammation, acute and chronic. In acute inflammation, again, it can be mild or severe. The mild form, which constitute about 80% of cases, with a mortality of about 1%, there is interstitial edema and mild dysfunction. Okay, so the inflammatory changes are mild. In severe pancreatitis, there is severe pancreatic necrosis, massive necrosis with severe dysfunction of the pancreas. And this accounts for 10 to 20% of the cases of acute pancreatitis. And this can have a high mortality, 20 to as high as 50% mortality. And this is due to multi-organ failure and septic complications that develop. The chronic pancreatitis, on the other hand, the inflammatory process continues either intermittently or as a prolongation of the acute pancreatitis. This leads to irreversible morphological changes in the pancreas, which lead to constant severe pain and permanent loss of pancreatic function. Okay, now we come to the actual topic for today, which is acute pancreatitis, which I said is the acute inflammation of the pancreas. Now, what are the etiology of this pain? In the vast majority, or nearly 80% of the cases, is due to biliary stones and alcoholism. And among the two, the most common is biliary choline, which accounts for 50 to 70% of the cases. Alcoholism is the second most common, and the other diseases or other causes include trauma, which can be blunt abdominal trauma, or surgical trauma due to post-cholecystectomies or post-ERCP procedures. Viral infections are important causes, especially in children. Mumps is a very important cause of inflammation of the pancreas to lead to acute pancreatitis. So is Coxsackie B virus. Hypercalcemia and hyperparathyroidism are another important causes of acute pancreatitis. The other less common causes include obstruction of the pancreatic duct, such as ampullary tumors, drugs, especially steroids, azathioprine and thiazides, Scorpion bite is widely classified as a cause of acute pancreatitis, malnutrition, and annular pancreas causing obstruction of the pancreatic duct, and autoimmune or hereditary pancreatitis, and another small group of cases known as falls under the idiopathic group. This chart here shows you a simplified version of the causes of acute pancreatitis. As I said, gallstones account for most of the cases, followed by alcohol abuse. And 20% of cases fall into other categories. The other cause categories include abdominal trauma, medications which I mentioned just now, infections, tumors, genetic and anatomical variants, high triglyceride levels, and high calcium levels. Now we come to the pathogenesis of acute pancreatitis. Okay, as I mentioned just now, there are three main enzymes that are secreted or produced by the pancreas. These include trypsin and chymotrypsin, which digest proteins, amylase, which digests carbohydrates, and lipase, which break down fats. In acute pancreatitis, what happens? There is an abnormal activation of these digestive enzymes within the pancreas, and this is through inappropriate activation of inactive enzymes, precursors called zymogens or proenzymes. And this inappropriate inactivation of these proenzymes inside the pancreas, notably trypsinogen, leads to massive autodigestion of the pancreas. Okay, so you have got noxious stimuli, various noxious stimuli, which activates the proenzyme known as trypsinogen to active trypsin, and this active trypsin proceeds with the massive autodigestion of the pancreas. Okay. This diagram shows you the structures related to pancreas, the lower end of the pancreas and the lower end of the bile duct, where the gallstones cause the obstruction. Okay, this is the head of the pancreas, where the pancreatic duct joins the common bile duct to enter into the second part of the duodenum at the ampulla oblata. And here is a close-up view showing a stone, small stone, as it passes through the ampulla oblata, causes a transient block of the pancreatic duct, and that triggers an acute inflammatory process. Okay, this slide is a simplified version of the pathogenesis of acute pancreatitis. Okay, the ultimate cause is acinar cell injury and the release of activated enzymes which cause all the problems: hemorrhage, fat necrosis, proteolysis, and interstitial edema. The causes that lead to these damages are: first, duct obstruction. The most common cause is gallstone. Secondly, direct acinar cell injury due to alcohol, drugs, virus, and trauma. The third category is defective intracellular functions within the acinar cell, and this can be due to metabolic aberrations, drugs, and obstruction of the duct by various causes. So all these three primary conditions lead to the activation of proenzymes and enzymes, and also interstitial edema. So all these things will predispose or result in acinar cell injury, leading to all the complications. This release of these enzymes triggers two types of inflammatory process. One is known as the interstitial type, and the other one is necrotizing type. This milder form is the interstitial type, which is an acute inflammatory process, and 90% of patients with acute pancreatitis fall into this category. the inflammation is usually mild in severity and may lead to a formation of local collection of fluid and cirrhosis. And this type of inflammation is associated with a lower mortality of 2%. The necrotizing is a more serious form of inflammation where the inflammation proceeds on with necrosis of varying degree, and about 10% of cases fall into this category. And usually the inflammation is moderate or severe in nature, and they may lead to shock and multi-organ failure. The clinical presentation of acute pancreatitis. First, the symptoms. These are the important symptoms or common symptoms that are usually seen in patients. Upper abdominal pain is the characteristically the pain is severe, and in the upper abdomen, the epigastric region and the upper umbilical region. The abdominal pain radiates to the back, from the front to the back, relief by bending forward or lying curled up. The abdominal pain that feels worse after food and is often associated with vomiting, nausea, and even retching. And this vomiting may be very severe and recurrent. The signs that you can see in patients with acute pancreatitis include fever, tachycardia, dyspnea, if it involves like effusion. Patient may or may not be jaundice, and if it's jaundice, the jaundice is usually mild, and that is due to the transient blockage of the pancreatic bile ducts as the stones traverses down into the duodenum. There is usually tenderness in the epigastric and paraumbilical region. And in severe cases, you may be able to see a grey turnus and Cullen sign, and very commonly there is intestinal ileus, which is detected by a silent abdomen or absent vowel sounds. Okay. So in mild pancreatitis, the patient may look well. In severe pancreatitis, he looks ill, toxic looking, confused, icterus maybe, tachypnea, tachycardia, hypotension, and even may come in a state of shock. Usually there is hypothermia, normothermia, and later pyrexia. There's epigastric tenderness, muscle guarding in the epigastric region. You may have ecchymosis at the flanks, which are known as grey turnus sign. Ecchymosis around the umbilicus, which is known as Cullen sign. And often there is abdominal distension from ileus or ascites. And in some cases, you may be able to feel epigastric mass, and there's massive necrosis or the formation of a pseudocyst. Okay, next we come to the clinical features. The symptoms, this is a picture of a classical picture of a patient with severe acute pancreatitis. Pain, acute onset. The site is the upper epigastric region, okay, and its character is severe, agonizing, and some people describe it as cruciating, and it's refractory to common medications. Radiation to the back and the lower abdomen. The aggravating factor is lying supine, so the patient tends to bend forward or lie on a curled up position. Relieving factors, sitting or leaning forward. Okay, this is another patient, pain right upper abdomen, left upper abdomen. Patient bends forward. This patient, the typical posture of a patient with acute pancreatitis, okay, lies curled up and with pressure on the epigastric region. This is another one, a curled up posture to relieve the pain. And this is the Cullen sign, ecchymosis around the umbilicus, and the grey turnus sign, ecchymosis around the back and lateral abdominal walls. And this is due to hemorrhagic pancreatitis that there's bleeding into the wall of the abdomen. Okay. This is Cullen sign around the umbilicus, ecchymosis. Gray Turner sign around the lateral abdominal wall, ecchymosis. Okay, ecchymosis, lateral abdominal and posterior abdominal walls extending to the upper part of the thigh. Next, we come to the diagnosis of acute pancreatitis. This is basically based on the medical history, the physical examination, typical abdominal signs in this condition, the blood test, serum amylase or serum lipase. The blood amylase or lipase levels are typically elevated 3 times the normal level during acute pancreatitis. The normal level, serum amylase, is less than 110 international units per liter and lipase less than 160 international units per liter. And CT scan is required in cases of severe pancreatitis, acute pancreatitis, and to detect the development of complications, which include necrosis, abscess, and pseudosis. Now, coming to the differential diagnosis of acute pancreatitis, these are the 4 common differential diagnoses that you have to entertain in a patient with acute pancreatitis: perforated peptic ulcer, acute cholecystitis, ascending cholangitis, and acute perforated appendicitis. Others include acute intestinal obstruction, acute mesenteric ischemia or gangrene of the small intestine or large intestine, acute MI, and rupture of an abdominal aortic aneurysm. Now, to assess the severity, a number of scoring scales have been used. The most common among them is called the RANSON score. Okay, this RANSON score, the assessment is done on admission and within the next 48 hours since the onset of the pain. On admission, these are the 5 criteria that are taken into consideration: age of more than 55 years old, white cell count of more than 16,000, blood glucose of more than 11 millimoles per liter, provided the patient is not a diabetic, elevation of the lactate dehydrogenase or LDH more than 350 units per liter, and elevation of the aspartate aminotransferase AST to more than 250 units per liter. So any of these parameters which are positive is scored given a point each, so a maximum of 5 points on admission. And then the patient is kept under close observation and monitored within the 48 hours, and these are the parameters that are checked for this patient. It's a fall in the hematocrit, blood urea nitrogen elevation, a decrease in arterial saturation, an increase or a fall in serum calcium, an increase in base deficit, and fluid sequestration more than 6 liters. So if any of these things are given, is positive, then the patient is given 1 point for each factor. And together, if the total score is less than 3, then the considered acute inflammation is mild. If it is more than 3, then it is considered moderate to severe acute pancreatitis. Okay, a score of 3 or greater predicts severe acute pancreatitis and possibility high mortality. Okay, here again the severity RANSON score used to help to predict the severity of the outcome of acute pancreatitis at 48 hours after the onset of the illness. Mild pancreatitis, less than 3 factors positive, and the mortality is around 2%, very much lower than 5%. Severe pancreatitis, when more than 3 factors are positive within the 48 hours, and this can be mild to moderate pancreatitis. Okay, if it is 3 to 4 factors, mortality risk comes to about 15 to 20%. 5 to 6 factors positive, mortality comes to 48%. If the 7 factors or more than 7 factors positive, mortality can rise up to more than 99%. Now, coming to the investigations of acute pancreatitis, first, serum amylase is very, very important. Okay, and this serum amylase normal value is 30 to 110 units per liter. So in acute pancreatitis, it is elevated to more than 3 or 4 times its normal, often 4 to 5 times its normal. And this increase occurs within days, within hours of the attack, and drops by a week, as shown in this graph here. Okay, it elevates, goes up very high, peaks within a few hours, 2 to 12 hours, and then after that slowly it drops down. Level comes to normal within 3 to 4 days. And the urine amylase is raised for 2 weeks from the time of the onset of the illness. The next is your serum lipase. Lipase has got a longer half-life, and its normal value is less than 160 units per liter. And the graph of its increase in the blood, in the serum, is shown in this graph here. Okay, increases 4 to 8 hours, peak in 24 hours, which is slower than the amylase. And then it goes down a bit slowly, and it can be positive detected in the serum for 1 to 2 weeks. Okay, level decreases in 8 to 14 days and remains elevated longer than the amylase. So this sometimes is a more useful investigation, because if the patient comes to you late, then the amylase, serum amylase may be normal, but the diastase will be positive. The third test is urine diastase. Okay, in the urine, to detect diastase level, if it is increased, then it indicates severe or acute pancreatic damage. What about the imaging in acute pancreatitis? Plain X-ray of the abdomen and chest can be done. You can detect localized ileus, and there are some classical signs that can be seen: sentinel loop, colon cutoff sign, and renal halo sign, radio-opaque gallstones or free gas under the diaphragm, pleural effusion, or interstitial shadows. Ultrasound of the abdomen is mainly to detect the presence of gallstones. CT scan, contrast-enhanced CT scan for severe cases, to detect swelling, necrosis, abscess formation, and pseudosis. Okay, this is a CT scan of a patient. You can see massive necrosis of the pancreas, whole pancreas, head, body, and tail. There's massive necrosis of the pancreas. This is on CT scan. MRI scan may be needed in cases where you can detect the presence of bile duct stones and also the status of the pancreatic ducts. Endoscopic ultrasound is sometimes done these days to look for the closer view of the pancreatic duct and the lower end of the CBD. Okay, this is a plain X-ray of the abdomen. It shows the cutoff sign, colonic cutoff sign. This is due to the inflammatory infiltration into the phrenicocholic ligaments at either ends of the splenic and hepatoflexure of the transverse colon, and this holds up the transverse colon in ileus, and this localized ileus is seen in a plain X-ray of the transverse colon, shadow from the right to the left across the abdomen. This is known as the cut-off sign. And this is an abdominal ultrasound of a patient with acute pancreatitis. Here you see this is an enlarged pancreas, the red shadow here, red enlarged pancreas, and here you see a dilated pancreatic duct. The yellowish arrow here shows you a dilated pancreatic duct. So this is a sign of acute pancreatitis on ultrasound. Here another X-ray, another ultrasound. This is the enlarged pancreas. Okay, and this is a collection of fluid around the pancreas, peripancreatic fluid, which is a sign of acute inflammation of the pancreas. These are some CT scan images of a patient with normal and acute pancreatitis. Okay, the one on top here is a normal pancreas. You see a clear shadow, and this is a pancreatic shadow. The tail here, the body, and the head. Okay, this is a normal size pancreas. In acute pancreatitis, you see the body, tail, and the pancreas. The whole pancreas is swollen and enlarged. Okay, so this is a acutely inflamed pancreas. And this is a pancreas with complication of pancreatic cirrhosis following acute pancreatitis. See, this is the head and body of the pancreas, and there is a cystic swelling with multiple septate within it. So this is a pseudocyst with septate and calcification. Now, what are the complications of acute pancreatitis? Can be either systemic or local. The systemic complications of acute pancreatitis are more common in the first week of the illness, especially in moderate to severe pancreatitis. The common ones are cardiovascular, hypovolemic shock and arrhythmias, lung, pulmonary atelectasis, pleural effusion, pneumonia, or in severe cases it can cause ARDS, acute respiratory distress syndrome, the renal complications, especially acute renal failure with oliguria and even anuria, due to severe intravascular volume depletion and acute tubular necrosis. Gastrointestinal complications are also quite common, especially paralytic ileus and dehydration, whereas gastrointestinal bleeding from stress gastritis in severe pancreatitis is another complication. The less common ones are hematological complications such as disseminated intravascular coagulation with bleeding tendency, metabolic conditions such as hypercalcemia, hyperglycemia, and hyperlipidemia, and neurological complications such as visual disturbances, confusion, irritability, and even encephalopathy and coma. Local complications of acute pancreatitis usually develop towards the end of the first week or the beginning of the second week. These include acute fluid collections that occurs early. In the early phases, it is ill-defined, and later it becomes walled off to form even a pseudocyst. Pancreatic necrosis, initially sterile, later infected to become pancreatic abscess. Pancreatic ascites, sometimes we need peritoniosynthesis. Hemorrhage into the gut, retroperitoneum or peritoneal cavity, this is in hemorrhagic pancreatitis. And portal vein or splenic vein thrombosis, as these veins are very close to the pancreas. Okay, this is a CT scan showing a massive necrosis in the head and body of the pancreas. Okay. This is a CT scan showing you a pseudocyst where the fluid collection becomes very nicely sealed off and by the tissues surrounding the cyst or the pancreas, and this is known as a pseudocyst. Here, a large pseudocyst in the pancreas. This is massive necrosis, early severe pancreatitis. Okay, there's massive necrosis in the whole of the pancreas. There's loss of architecture and irregularity of the pancreas, and later it gets infected, usually towards the end of the first week, and then it forms an abscess, which may need surgical drainage. The treatment of acute pancreatitis. First, the general resuscitation and initial or supportive treatment. This is of utmost importance in a patient with acute pancreatitis. This treatment includes replacing of fluids and electrolytes, adequate early resuscitation with fluids and electrolytes, especially within the first 24 hours of onset of the disease. Secondly, nutritional support is important because this patient has to be kept nil by mouth for some time, and as such, enteral or parenteral nutrition should be considered. Early enteral feeding via nasogastric tube should be encouraged. Thirdly, pain control. Since pain is a very serious accompaniment of this condition, adequate control of the pain must be undertaken. Usually, these patients will need opiates like morphine and pethidine, IV infusions to control the pain. Treatment of underlying issues should be given due consideration, especially acute renal failure, multi-organ failure, and the removal of the stone, which is a causative agent for the acute pancreatitis. Certain drugs have been found to be useful in this medical management of acute pancreatitis, such as stomatostatin or its analog, the octreotide, proton pump inhibitors, and antibiotics. Somatostatin reduces the pancreatic secretion, whereas the proton pump inhibitors will prevent stress ulcers, and antibiotics to treat the infection. These patients with acute pancreatitis, especially the moderate to severe cases, need to be intensively monitored in ICU or HDU. And definitely early endoscopic retrograde cholangiopancreatography or ERCP should be considered as soon as the patient is stable. Then we come to the surgical management of acute pancreatitis. So, in the treatment, the definitive treatment is resuscitation and supportive treatment to stabilize the patient. ERCP and early ERCP and sphincterotomy, and laparoscopic cholecystectomy, either delayed, immediate, or delayed depending on the patient's condition. For the complications that develop, local complications that develop following acute pancreatitis, especially for pseudocysts, drainage of the pseudocyst is important, and this is done by draining the cyst into the stomach by a cyst gastrostomy, okay, creating a fistula between the cyst and the posterior wall of the stomach. If there's massive necrosis, then a necrosectomy have to be done. This is a form of debridement of the pancreas. If the secondary abscess formation has set in, then drainage of the abscess becomes a very important treatment to control the sepsis and septicemia. Okay, these procedures, cyst gastrostomy, necrostomy, or drainage of the abscess, can either be done through endoscopically, laparoscopy, or many cases may still need open surgery to get a clearer drainage or debridement of the pancreas. A few words about pancreatic pseudocyst. Pancreatic pseudocyst is a collection of amylase-rich fluid enclosed in a wall of fibrous or granulation tissue. It usually occurs 4 weeks or more after the acute attack of pancreatitis. It can also occur after chronic pancreatitis or after pancreatic trauma. The clinical presentation is usually quite straightforward. a non-mobile, non-tender epigastric mass which is progressively increasing in size. The complications of this pancreatic cirrhosis include infection leading to abscess and sepsis, rupture of the cyst into the gut causing intestinal bleeding or intestinal fistula and peritonitis, compression of the biliary tree causing obstructive jaundice is the pressure effects, bowel obstruction, especially duodenum, where it can cause obstruction and cause duodenal obstruction, and sudden pain from hemorrhage into a pseudocyst. Suddenly, patient develops severe pain and the pseudocyst increases in size. So this is due to hemorrhage. The treatment for this pancreatic cirrhosis is surgical drainage. Percutaneously can be done transgastric cyst gastrostomy, or if the patient is fit enough, then through the either endoscopic or open cyst gastrostomy should be done. Okay, this is an open gastrostomy just to illustrate what is the cyst gastrostomy is all about. This is the anterior wall of the stomach that has been opened up to reveal the posterior wall. Okay, open the posterior wall, anterior wall. You see the posterior wall, there is a pseudocyst, is adherent to the posterior wall. So what you do is you make an incision and create a fistula between the cyst and the stomach. That is the cyst gastrostomy. And the edges of this anastomosis are sutured with fine sutures. And this cyst gastrostomy will drain all the pancreatic fluid and necrotic tissue into the stomach, and it will be drained away, and soon the cyst will collapse and close the fistula. Okay, finally, this is a flow chart to show you the management of acute pancreatitis. Patient comes with acute abdomen, clinical enzymes and CT scan confirms acute pancreatitis. You classify them according to mild, moderate and severe. Mild cases, careful monitoring, aggressive resuscitation, analgesia, nutrition, drugs, somatostatin and antibiotics. And when the patient is stable, you subject the patient for a ERCP sphincterotomy and laparoscopic cholecystectomy. In moderate cases, besides all this treatment, there may be local complications which may need surgery. And these complications will be pseudocyst, necrosis or abscess, and this surgery is cystogastrostomy, necrosectomy and abscess drainage. In severe forms, you have to go through very aggressive treatment in ICU, multiple organ failure has to be reversed, and patient needs ICU and supportive treatment. Okay, if the patient improves, then you subject him to the various surgical procedures as in moderate pancreatitis. Okay, and those will be the triple surgery: cyst gastrostomy, necrosectomy and abscess drainage. And finally, these patients should be still subjected to a ERCP with sphincterotomy and lap cholecystectomy. Thank you for joining me for this lecture on acute pancreatitis. Hope to see you again in another lecture.